Hello everyone, welcome to part 2 of this awesome case study that I'm doing. My name is Dr. Ernesto Medina from True Integrative Health, Holistic Health, and Functional Nutrition. Hopefully you're tuning in after watching part 1. If you haven't watched part 1, it should be up on my YouTube channel because this part 2 is going to make a lot more sense after you watch part 1. But basically we're continuing on with the second half of this case study of my wife, and like I mentioned at the end of the previous video, we're going to be looking at all the medical specialists that she did see, the continuous misdiagnosis over and over again that she kept getting. We were able to get a full vestibular system evaluation, which is called a V&G study that we had to fight to get, but I wanted her to get one so we could have some hard data points on what was happening with her vestibular system. We're going to cover some of the brain rehabilitation strategies we implemented, as well as another doctor helped implement to get control of her symptoms and get her headed in the right direction. And we also went to a neuro optometrist, and I'll explain a little bit more about what we did there and what that is, to see if we can get some more guidance on how to better help my wife start feeling better instead of regressing further. All right, so like I mentioned, let me move myself out of the way here. There we go. All right, so like I mentioned, so after my wife ate that piece of donut, her symptoms kind of flared up and exacerbated way more intensely. After that event happened, she started experiencing severe nausea and upset stomach triggered by movement and visual stimuli. And meaning basically movement definitely aggravated her nausea and her upset stomach, but it got to the point where she wouldn't even have to be moving. If she would look at something moving outside, or if she looked at a busy visual, for example, a TV with flashing lights or with lots of visual moving pieces on the TV, that would trigger her symptoms. It got to the point where she could not even read or look at a computer screen that had text on it, because that would really trigger her symptoms quite a bit. And so a lot of her triggers I have listed here: computer screen, cell phone, television, car rides, a walk to the park, seeing all the passing trees would also visually overwhelm her, trigger sensitivity in her eyes, and then trigger all her nausea and upset stomach symptoms. And when that would get really bad, that would progress into extreme sensitivity to light and to sound. And then head pain. Head pain was accompanied with all of this, and that was kind of a more of a later on symptom that would come on, but it would be pretty sharp head pain that would come on quickly. And there were certain therapies that we could do that would actually make it go away just as quickly as it came on. But if we didn't do any therapies on her, that head pain would linger for hours and hours. And of course, the fatigue came back with a vengeance. So because this huge flare-up of her symptoms occurred, I wanted to make sure I wasn't missing anything more severe, because at this point I was acting as her primary care, and so I wanted to make sure I got second opinions, third opinions, to make sure I wasn't missing anything. So I had to go see her primary care doctor. Primary care doctor listened to what she had to say, didn't have much to offer, pretty much said, well, for the headaches, we can send you to neurology and have them work you up and see what they find. For the irregular heartbeats and the potential POTS or the orthostatic intolerance issue, send you to cardiology to get a tilt table test. And then that was really all she had to offer. At this point, my wife wasn't really able to work. She couldn't look at a computer screen. She couldn't read anything without triggering severe symptoms for her. So she was hoping to get a short-term disability signed off so she can focus on finding a provider that would help rehab or fix the problems that were going on. But of course, she was denied. She was denied mostly because the primary care didn't know what to do, didn't know what to diagnose her with, and said it's not her responsibility. She's got to see neurology or cardiology. And of course, this was right before the holidays. This was in November. And so any neurology or cardiology appointments were about 2 to 3 months out. And it was already challenging enough to find a cardiologist with a tilt table to be able to do this testing. And so we struggled to find a referral fast enough. But if you remember from the first video from part 1, I mentioned that when I examined my wife, I had found a pretty big vestibular deficit issue because she had pretty pronounced balance and spatial awareness loss. And so I hadn't done anything really to actively improve that. Really, we were focusing on controlling inflammation through changing up her diet and some targeted supplements to help improve circulation and blood flow. And I wanted to see how much improvement she would get from that, and if we even had to do much with the vestibular issue. But now with this massive flare-up, I knew we definitely had to get an evaluation of the vestibular system and start doing some specific rehabilitation for that system. So I recommended my wife go see an ENT. ENT stands for eyes, ears, nose, and throat specialist. And there are ENTs that specialize in vestibular issues and vestibular assessments. For whatever reason, and I'll talk about this in a bit, but for whatever reason, the ENTs we saw were not very, how can I say this nicely? They weren't very educated or interested in evaluating my wife's vestibular system very thoroughly, or thoroughly at all. But of course, before you see the ENT, we had to go see an audiologist first. That was required for whatever reason, probably for insurance purposes. I don't really know. So we had to pay to get an audiology workup, make sure that she was at least hearing things fine. She passed that test, and then we could finally see the ENT. We ended up seeing a PA, which is a physician's assistant ENT, not an actual MD ENT, but that was fine. He spent a lot of time listening to her symptoms, really offered some pretty good insight, which was nice, but could not do a VNG study for us. He had to request it from another office, and again, that was probably 2-3 months booked out to have a VNG study done. And so he referred us to a private office ENT to request a VNG study done. And for those of you who don't know what a VNG study is, it's basically a computerized assessment of vestibular function, comparing right to left. And it has many other different variables in it, but it's basically a computerized assessment that gives you specific graphs and data points as to what the vestibular system is doing and is able to pick up on subtle differences from one side to the other. But after meeting with the PA ENT, his conclusion was that it sounds like vestibular migraines is the issue. And according to WebMD, vestibular migraine is a nervous system problem that causes repeated dizziness or vertigo in people who have a history of migraine symptoms. Unlike traditional migraines, you may not always have a headache, right? So, I mean, it made sense, the vestibular migraine theory. However, my wife did not have a history of migraines at all, not even headaches, until just recently. And she wasn't really getting dizziness. It was more a quick bout of dizziness that subsided quickly, and then nausea and eye sensitivity and then a sharp head pain. And so it didn't fit the classic vestibular migraine presentation, but I said, okay, well, we'll take it and see what else we can find from that. So from there, we went to go see a vestibular therapist, a physical therapy vestibular therapist. And again, we were hoping maybe we can get a VNG study through this office, because they are vestibular specialists. That's what they focus on. And so my wife had a 1-hour assessment. It was actually a pretty good, thorough assessment. They were able to recreate all of her symptoms pretty significantly. At the end of that visit, my wife she felt terrible, which sounds bad, but in a way it's a good sign that they're able to recreate the symptoms because they know what's triggering it, right? And essentially it was just a physical vestibular assessment. And so they could not do a VNG study for a couple months out either. And they had an audiologist on staff that does it. And so we ended up not getting the VNG study done there, but we did get an assessment, and the conclusion of that assessment was there was definitely a vestibular imbalance present, right? We already knew that. I already knew that. We had it confirmed through this office. And the plan of action was essentially just doing vestibular rehab, right? Okay, great. Now, we still wanted to get a VNG. I still wanted her to get a VNG study done so we can get some hard data points on what is going on with the vestibular system. Is the deficiency right? Is it left? Is it a posterior issue, or what is it? And so I mentioned to the therapist, I said, well, we're planning to get a VNG study done. Do you recommend we get one? And will your treatment change based on the results of the VNG study? And she basically told me, no, her therapy will not change depending on what the VNG study tells her. She treats based off just what her exam findings are. And she also said she did not recommend having the VNG study done because many times it finds things that don't correlate to what the problem necessarily is. And so she recommended against it. So from there, we went to go see the second ENT that we were originally referred to, really because we wanted a VNG study done. But of course, we needed to see the doctor there first before they can make the request for a VNG study. So we wasted a visit there. Let me take a step back. So we did see that ENT. Who was a medical MD ENT. She spent 5 minutes pretty much interviewing and did a quick assessment of my wife and said, yep, it's definitely vestibular migraines. But if you want a VNG study, we can place the order for you. So great. We spent, I think, $250 for that 5-minute visit and evaluation just so we can get approved for a VNG study. The VNG results showed that she had an issue called BPPV of her left posterior canal, as well as a 24% vestibular function loss on her left side compared to her right side. So I was pretty thrilled that we found this because this confirmed what we already suspected, but it gave values to what we were suspecting. However, the interesting thing was when the medical ENT reviewed the results with my wife, she essentially concluded that the VNG results were normal and that she would just recommend treating the vestibular migraines. And so having a 24% vestibular function loss left compared to right, the threshold was 20%. So anything over 20 is considered significant according to the data results. However, she dismissed the significant findings and stuck to the issue being vestibular migraines and wanted to just medicate with either migraine medication or steroid medication or antidepressant medication for the vestibular migraines. And so really, I wasn't happy with that. However, we got the VNG study done. That's what I wanted. I wanted those data points. And so then we went on to the next doctor who was a board certified chiropractic neurologist, right? And now I had specifically looked up this doctor because I'm familiar with the chiropractic neurology world. I've trained in functional neurology, and so I wanted to get a second opinion from someone who was speaking my language, right? Who's going to see what I saw and see things that I missed. And so we contacted them, had an opening, we got in. This doctor spent probably about 90 minutes with us. He did a 1-hour full evaluation, testing the nervous system, testing balance, testing coordination, many things. And his conclusion was very similar. He found definitely a vestibular imbalance issue on the left side. In addition, he found that she had a left eye muscle weakness causing lack of convergence, meaning lack of her eyes being able to come together when she's looking at something up close. And it was very evident in the left eye over the right eye. And so this was causing an issue of dysconjugate gaze, or what I found out the diagnosis term is called binocular vision dysfunction. And this, I believe, this dysconjugate gaze issue was a major contributor of why she became so sensitive to visual stimuli, because her eyes were essentially not looking at the same target, the same focal point together. Of course, and then the treatment for this was going to be specific brain rehabilitation, similar to the physical therapy rehabilitation place we had gone to. However, this was going to be super specific to the weaknesses my wife had. So specific to that left eye muscle weakness and specific to the left vestibular system. And so I was much happier with a specific targeted rehabilitation program. That made more sense to me, especially given the VNG data points that we had gotten. Right, so if you remember vestibular system, I spoke about this in video 1. The semicircular canals, the vestibular nerve, the cochlear nerve, this whole system is part of the vestibular system. Inside of these canals, we have fluid. When the head moves, the fluid moves. That signals to our brain that we are moving. And what I didn't mention in part 1, which I'll mention here, is that head movement that triggers movement of the fluid in the inner ears also triggers equal and opposite eye movement, right? And so that vestibular inner ear system helps coordinate position of the eyes and movement of the eyes, especially with movement of the head and the body. And so this diagram basically shows these blue circles are the vestibular system. Fluid moves inside of these canals, which fires out to cranial nerve 8, which is in the brainstem, which then fires out to cranial nerve 6, also in the brainstem. And then this fires out either directly to the muscles that control the eye, movement of the eye, or out to cranial nerve 3, also in the brainstem, that then controls opposite muscles of the eye. This diagram basically shows you the same thing. You can see here the head moves, triggers the fluid in the inner ear canals to move. That fires into the nuclei of the brainstem, which then fires up into the nuclei of the nerves that control movement of the eye, and that in turn fires out into the eye muscles, triggering movement of the eye. So her focused specific rehab, brain rehabilitation, was things like this. You can see here she has a laser on her forehead. There's a green light here, a little difficult to see, but her eyes are focusing on the green light as she moves her head in different movement patterns to recalibrate movement of the head with movement of the fluid in the inner ear and movement of the eyes. And similar here, this was done at our home office. I pretty much had a lot of this equipment at home, and I had built a rehab space for her in her office. So this was done at home. On the right, this picture here was actually done in the chiropractic neurologist's office. So he was doing similar things with the laser. You can see the red dot there, and different movement patterns just to help recalibrate information from her head and her neck, coordinating with the inner ear and coordinating with the eyes. Here you can see the doctor again and my wife focusing on a point, this being her thumb that she's focusing on, and he manually turning her in the chair to stimulate a specific vestibular side, right? For her, it was the left side. So she was spinning to the left as her eyes fixated on a point, which is her thumb. And she was being spun slowly to activate that vestibular system, to recalibrate it with the eyes. And for that left eye weakness issue she was having, another exercise she did was called a Brock string exercise here. So you can see the picture on the right. The string has a set of balls. The balls have different colors. Her job is just to focus her eyes on each color ball as instructed. And the closer, for example, the green ball, the closer the ball is to her face, the more her eyes have to converge inwards to focus on that ball. And you can see at the very beginning of doing this exercise, it was very strenuous. You can see a picture on the left side, how much her eyes would strain. It would trigger a headache, fatigue and pain, even head pain sometimes for her. And so these balls can be moved to different distances to help retrain that system of her eyes coming closer and closer inwards and together. The stronger the eye gets, the less pain there is, and the closer the ball can be moved to her face. And so like I explained earlier, convergence, you can see here, an object close to your face, the eyes come in together to meet at that point. If there's a point farther away, the eyes actually open and diverge, and you can see the line of sight is much wider versus crossing here. And if you focus your attention on this top diagram here, you can see similar thing. If there is a right eye weakness in this example, and you try to converge at a point that's up close, having a right eye weakness doesn't allow that eye to come inwards. Only the left eye comes in and the right one stays out. And this is what my wife was having. She was having a left eye convergence insufficiency issue where it just wasn't coming in. And so this made it very difficult to read things, to look at computer screens, and to look at things up close. All right, so like I mentioned before, in this example, balance and spatial awareness was largely affected. Her vestibular system was a big contributor. A big deficit of her vestibular system was contributing to a lot of these symptoms, which caused her brain to highly rely on visual input to increase her awareness of her surroundings. That increased visual input, or dependency, I should say, the increased dependency from the brain on the visual system caused her to become very visually dominant. And that's why too much busy stimuli or even bright lights would trigger a lot of her symptoms. So the last doctor visit we saw was a neuro-optometrist. Now I knew of neuro-optometrists because of my functional neurology training. I sat in on quite a few presentations from neuro-optometrists in some lectures. And they treat a lot of the same issues of post-concussion brain injuries that cause deviation of eyes or disconjugate gaze issues. And so I wanted her to get a neuro-optometrist workup to see what their opinion was, to see if they could offer any kind of special lenses to help reposition her eye to where we could do more therapy and she could recover faster. And so there's the definition of a neuro-optometrist. It's a rehabilitation optometrist specializing in the diagnosis and treatment and rehabilitation of neurological conditions adversely affecting the visual system. Neurooptometric rehabilitation is a process for the rehabilitation of the visual, perceptual, and motor disorders. Okay. And so she did it. The neurooptometrist we saw, there was only one in Austin that I could find. And she did a very thorough 3-hour examination. I sat in on the entire exam. It was great. It was very thorough, very comprehensive. And her conclusion was that she did in fact have a binocular visual dysfunction issue, meaning her eyes were not looking at the same target all the time together. One eye would veer off due to its weakness. And although she wasn't seeing double vision, her brain was making up the difference in what they were seeing and just focusing on one eye and being able to create just one visual picture versus creating double vision. And it was her professional opinion that she in fact did not have vestibular migraines. A lot of the symptoms mimic vestibular migraines, but she believed it was not vestibular migraines at all. It was actually binocular vision dysfunction. She could clearly measure the difference in eye position from left to right. However, she was not able to find a special lens weak enough to properly align my wife's vision to even. And so I was thankful for the examination and the workup she did. Again, she confirmed what I was suspecting. However, she couldn't offer us too much as far as solutions. She believed the vestibular system was a huge player in her binocular vision dysfunction, and she recommended we continue doing the rehabilitation, and over time it should continue to get better. And then the last doctor we saw was a medical neurologist, and really this was because all the other specialists we saw mentioned that we should see a medical neurologist because they were all under the assumption her issues were vestibular migraines and nothing else. And so we went through the process of seeing the neurologist, and essentially it was a 45-minute conversation my wife had with the neurologist. Really, there was no assessment, no examination, no testing done. It was just a conversation, and his conclusion was that my wife just had simple headaches being caused from a tight neck. That was all. She looked fine, and so there was no reason for her to be complaining of all these symptoms, and pretty much just wrote her off, brushed her off, ignored the severity of her symptoms and the length of time she had been dealing with the symptoms. He recommended a medication for the headache and referred her again, so another referral to a headache clinic. And so that was pretty much a pretty useless visit. My wife was very frustrated when she left that appointment because she didn't feel heard, and she didn't feel as though the medical neurologist had really done anything as far as investigating into why she was having so many debilitating symptoms. So that was her journey. 4 months later, after all these visits and continuous brain rehabilitation, she's about 80-85% improved with her symptoms. She can now tolerate exercise, which has been great because if she ever does feel off or dizzy, exercise is actually helping improve her symptoms now, where at the beginning exercise would flare up her symptoms. So she's back hitting the gym, CrossFit 5 days a week, and she's loving it. She still struggles with computer and visual stimuli. She can tolerate about 1 to 2 hours of computer time before she starts to get head pain and eye pain. But that's a big improvement from 5 minutes, right, at the beginning of all this. She can tolerate walks to the park okay, with no major issues, and she can ride in the car much, much better. She still sits in the back seat because there's less visual stimuli in the back seat, but she's tolerating it much better without massive symptoms. She still struggles with doing some nearsighted tasks. So again, that left eye weakness of the eye coming in together with nearsighted tasks is still a struggle, but we're still working that rehabilitation with her. I don't have any doubts that it will continue to improve. And that's it. And so, again, thank you for your time in watching these case studies. I hope that the information is beneficial to someone out there also struggling with these chronic symptoms. If you have questions, if you're looking for another provider or someone to offer you some answers, please check out our website. Check out, let me see here. No, I don't have it. So please check out our website. Check out our Instagram and our YouTube channel. You can see there for more patient testimonials. Thank you very much and have a good day.